Thank you all so much for joining us. I know we're going to be joined in a moment by folks on Facebook and Twitter. So I'll introduce myself twice. My name's Andrew Romanoff. I'm a candidate for the United States Senate. We're joined today by a distinguished guest I'll introduce as well, and by several thousand folks across our platforms. If you're interested in joining these town halls in the future, we're doing these events every Friday at noon Mountain Time and every Tuesday at 5 p.m. Really appreciate your interest. I hope you and your families are staying safe and healthy. It's my commitment and the commitment that we're making as a campaign to do everything we can to connect people with resources throughout this pandemic. You can learn more at andrewromanoff.com. We're joined today by a man who inspires me and many of us who have followed the movement for universal single-payer healthcare. It's one of the defining issues of our time. If we're going to get there, we need not just a new president, we need a Democratic majority in the Senate that shares a commitment to providing healthcare for all, so that when we emerge from this pandemic, and we will be in a place where all Americans get the care they need that no longer depends on their job. That's the crux of our campaign, and it's now the life work of Wendell Potter. So I want to say, Wendell, thank you. I know we may be joined during this town hall by Charlie Potter too. You might provide a word of introduction in case he barks his way in. But I want to say thank you for your leadership, and I hope you can hear me okay from Philadelphia.
I sure can, Andrew. Thank you so much for asking me to join this today, and thank you for offering yourself up for the U.S. Senate, and anything I can do to help you and other candidates who support Medicare for all, I'm all in.
Thank you. I really appreciate that. And for the folks who may be just new to you, maybe new to me, but you could provide, I hope, a bit of a word of introduction as to how you came from a career in the private insurance world to being a leader now in the Medicare for All movement. Can you tell us a little bit about how you got from there to here?
I sure can. First, I'll just say that in my first career, I wasn't always a health insurance company executive, which I will explain in just a second. I was a newspaper reporter in my first career, but I had a longer career in healthcare, and I worked initially for a healthcare system in Tennessee before being recruited to Humana. And that was my first for-profit company that I worked there for 4 years, and then was recruited to Cigna, where I worked much longer. I led communications for both of those companies. I was vice president of corporate communications for Cigna when I began having a very significant, as I've called it, a crisis of conscience. I began to realize that what I was doing for a living was perpetuating a very dysfunctional and unfair and overly expensive healthcare system. I was expected during that time to also be a champion for high deductible health plans, because it was the industry's strategy to move every last one of us into a high deductible health plan. It's apparent why that's good for the insurance industry, because we have to spend a lot of money out of our own pockets before our coverage will kick in. So I was having misgivings about that. I knew that these plans were not good for middle income families, certainly not for low income families. But there were a couple of other things that happened during the year. It was actually 2007 when I began to question what I was doing for a living. I went to an outdoor health clinic near where I grew up in Tennessee, and saw people literally standing in long lines that stretched out of view at a county fairground waiting to get care that was being provided by doctors and nurses and dentists who were volunteering their time. And they were treating patients in barns and animal stalls. And it was just an overwhelming experience for me. I realized that had I not been lucky to have been born to parents who sacrificed so I could go to college, I might have been one of those people, that there could have been neighbors of mine in those long lines waiting to get care in a barn or an animal stall. And then a few months later, I had to handle, along with my team, what we referred to as a high-profile case, in which a young woman in Los Angeles, 17-year-old girl actually, needed a liver transplant, and my company refused to pay for it, saying that Cigna felt that it was an inappropriate procedure for Nataline Sarkeesian. Long story short, the family made it a big public relations problem for Cigna. The company finally decided to reverse that denial, but Nataline Sarkeesian died at age 17, 5 days before Christmas in 2007. And I turned in my notice a few weeks after that, and have decided I would try to be someone to help the public understand how health insurance companies really operate, and what we can do to move beyond a system that is controlled by big for-profit health insurance corporations.
First of all, I want to say thank you for sharing the stories, because I know it's easy to get lost in a conversation about millions of people and lose sight of the individuals whose lives are at stake. It's certainly what grips me in the work I did at Mental Health Colorado, and I can share some stories later if we have time. I wanted just to frame our conversation, and I'll do my best John Oliver impersonation here without with the expletives deleted, but just we're going to talk a little bit, I hope, about the problem we're trying to solve, how we solve it, and how we get from here to there. I want to see if we're on the same page in terms of the problem. By my count, your mileage may vary, we've got at least 72 million Americans uninsured or underinsured, 500,000 driven into bankruptcy each year because of the cost of care. And at a conservative estimate, I'm told 35,000 people dying in the richest nation on the face of the earth because they can't afford to see a nurse or a doctor. Is that about right by your standards here?
Yes, if anything, your numbers are a bit on the low side. Particularly now, as we are in the midst of this pandemic, we're seeing that millions and millions of people, I think 26 million so far that we know, have lost their jobs as a result of this pandemic. And along with those jobs, many people have lost their health insurance because we have this absurd system in this country in which most people who are not eligible for a public program have to rely on their employers for health insurance. So this pandemic, if nothing else, is pointing out the absurdity of that. And we had, even before this pandemic began, close to 30 million people who were still uninsured 10 years after the Affordable Care Act was passed. And at least twice that many are underinsured, which means that they're in these high deductible plans I mentioned, who are unable to pay out of pocket for the care that they need before their coverage kicks in. So that's what it means to be underinsured. You and your employer, in many cases, are paying good money every month for health insurance, but you can't use it because of what you are obligated to pay out of your own pockets before your coverage kicks in. And yes, as a result of all that, probably an untold number, but at least 30 to 40,000 people die every year because of having no insurance or having inadequate insurance.
When I was working in Mental Health Colorado, I met a lot of folks around our state who liked their insurance plans until they had to use it. And then they found out it didn't actually cover what they thought. I remember in particular a dad I met whose son had deep depression, psychosis, needed treatment, couldn't get it. His plan was supposed to cover it. The insurance company continued to delay and deny the claims until his son killed himself as a teenager, and then sent a letter to the dad a few months later from the insurance company saying that they had reversed their decision and agreeing to cover the claim. Just heartbreaking and agonizing. It makes me so angry. And it's not the only consequence, right? Can you talk a little bit about the health outcomes that we're getting in return for the money we're spending? Because we're paying nearly twice as much as other industrialized nations on healthcare that's not actually twice as good.
Yeah, we actually pay more than twice as much as the average of other developed countries in the world, and more than $10,000 per capita for health insurance, for healthcare in this country, about $3.6 trillion in overall, and about a third of that, it's been estimated, doesn't go to keep us from getting sick or getting us well. It goes to overhead caused largely by our multi-payer system that's, again, controlled by for-profit insurance companies. Our outcomes are, at the same time, much worse across the board than they are in other developed countries. So we have this situation in which we pay far, far more, twice as much as the average of other developed countries for healthcare, yet our outcomes are so much lower across the board. The Commonwealth Fund routinely evaluates the performance of healthcare systems around the world, and they've been doing this for many years, before the Affordable Care Act and after, and consistently, even after the Affordable Care Act was passed, which I supported and have written a lot about and has done some good. But still, to this day, we fall far short and far behind all the other developed countries in the world in terms not only of health system performance, but in terms of outcomes. We don't get much bang for our buck in this country.
We're being flooded with questions and comments, and I know I'm not going to be able to do justice to all of them. But one person's asking, and if you're just joining me, our guest is Wendell Potter, single payer champion, president of Business for Medicare for All, Business for Medicare for All now. Folks are asking us to distinguish between the delivery of healthcare and the reform of health insurance, because both need fixing. Do you want to just help us define the terms as we go through this conversation?
I will, and I've mentioned the Affordable Care Act, and also known as Obamacare. It addressed largely health insurance reform, and what we're talking about now, when we talk about Medicare for All, we're talking about changing the way we finance healthcare to a large extent, from this multi-payer system to having a single public program in which everyone's enrolled in. So there is a distinction. It's an important one. We really need to address how we pay for healthcare in this country, because we do it in the least efficient way possible. There's no other country in the world that has a system that is as fragmented and inefficient as ours. So that's one of the important jobs we have to accomplish, and that moving to single payer and Medicare for All would help to accomplish. The Medicare program that we've had in place in this country is much, much more efficient. The overhead, the administrative costs on a per enrollee basis in Medicare is far less than it is on the commercial side or the private insurance side. So that's an important distinction. The legislation that has been proposed in both the House and the Senate, in the Senate by Senator Bernie Sanders, and on the House, the principal sponsor is Pramila Jayapal of Seattle, addresses changing how we pay for or finance healthcare. And what we're talking about when we're talking about Medicare for All, it's similar. It is exactly the same arrangement as the Medicare program. In the Medicare program, you have this single payer, which is the government, but healthcare is privately delivered. So it's different from what the system in the United Kingdom is like, the National Health Service there. It's also, it provides financing, but in many cases, hospitals are owned by the NHS, the National Health Service, and doctors are employed by it. What we're talking about here is more like the Canadian system, which is also called Medicare, in which the government has a single payer, but the healthcare delivery is provided privately. And along with that, you need to address how can we improve the delivery of healthcare, not just the financing of it. So both are important, and the legislation that is, whatever is passed, has to address both, not just the financing.
I want to try to unpack everything you just said, because it's a really dense issue, but most Americans can understand, as you put it in a tweet I saw the other day, that people are getting sick and dying. Doctors and nurses are risking their lives to save them. And meanwhile, the private for-profit insurance industry is making out like bandits. So that is a problem, at least in my view. Maybe not if you're running one of the insurance companies. But certainly these problems existed before the pandemic hit. And perhaps the crisis we're in now has made those problems more apparent and worse. We could talk a little bit, as we're going to do in the town halls ahead, about economic inequalities and why this pandemic is taking such a disproportionate toll, particularly on the African-American community. So I'm glad that you distinguished among different systems. You should know, but probably more information than anybody needs, that my appendix still rests at the NHS, because I was living in London at the time it burst. And the system that you and I are supporting doesn't require the government to employ all the doctors and nurses and healthcare providers or run the hospitals. Although there are systems like that, and there is a system like that in the US through the VA, among other places. But you're talking about a public universal insurance pool and privately delivered healthcare.
That's correct. That's exactly right.
So the term Medicare for All has struck some folks, including me, as a little misleading, because the Medicare program we have now doesn't cover everything it should, like dental, vision, hearing, and long-term care. And many places, especially in rural parts of Colorado and throughout the country, see providers who are reimbursed at rates that are too low to survive, just the Medicare itself. So we're really talking, tell me if I'm wrong here, about new and improved Medicare for all.
You're absolutely right. Yeah, even the system that exists for those who are enrolled in the Medicare program now, it needs to be revamped. It needs to be improved because if you're in the Medicare program, you have an obligation to pay out of pocket a certain percentage of the care that you get in some cases. So a lot of people have to buy and do buy Medicare supplement policies, which are sold by private insurance companies to pay to cover that gap. So we need to have a Medicare program that addresses that. and that moves people into a system in which they don't have to pay a lot out of their own pocket for care. As we were talking earlier, that's been the trend in the private system as well. We're talking about improving the Medicare system for everybody, including current enrollees, but also those who will be coming into the system, to also include things that are not covered, like vision care and dental care and hearing care and long-term care. Those are all important things that have not been a part of the current Medicare program, and also to vastly improve the the pharmacy benefit for Medicare beneficiaries. When that was added, when pharmacy was included, or including drugs in the Medicare program back in 2003, the insurance industry and the drug companies were able to convince Congress to include the benefit in a way that really benefits those industries. And it's very complicated and confusing. So and they also made it impossible for the Medicare program to negotiate directly with drug companies to bring down the cost of care. So you're right, we need to improve it, make some changes that have been put in place over the years, like really changing that drug benefit program in particular.
One of the viewers is asking, why not call it healthcare for all instead of Medicare for all, given the fact that the Medicare program we have now is not exactly the system that we would be expanding to everybody.
Yeah, I think that's fair. Medicare for all came to be a term that a lot of advocates use because people are aware of the Medicare program. Previously, people talked about single-payer healthcare, which is another term that's been used for a long time. It's not all that understood by regular folks, so it took some explaining why single-payer needed to be, or there needed to be some term for it. I don't think we've necessarily landed on the exact phrase, but I think that's right. What we need is universal health care that is delivered in a way that control, and also a system that controls healthcare costs and makes sure that we have improved outcomes.
I've suggested at one point, and I haven't had a chance to address this to a national audience, that we call this plan the American Health Freedom Act, because really what we're talking about is coverage that doesn't depend on your job or your income or your age or your zip code. Coverage that goes with you, whether you lose a job or change jobs or start a new job. And it strikes me as an important point now, when 26 million Americans, including about 300,000 in Colorado, have already filed for unemployment, when some projections suggest 47 million Americans may be out of work, and many of them depend on their job for their coverage. I don't want to get too far into the history lesson here, but we've talked in previous town halls about the fact that this employer-based insurance system is not a law of nature. It's just an accident of history,
Exactly.
the product of decisions the feds made back in World War II to freeze wages and to make benefits tax-free. So there's nothing particularly logical or efficient about it, and especially during a recession like we're in, or a depression, which we hope to avoid, the requirement that you get your coverage through your employer, or the nexus between the two, strikes me as a particularly disastrous experiment. It's just one that we've conducted for 80 years.
Absolutely. I like the name. I like the name you've offered up there. I think that when you're in the Senate, introduce that bill. I like it a lot.
You heard it here first. So a lot of folks are asking us how to pay for it, how to implement it, how we're going to get it passed. But I want to make sure that we're still on the same page in terms of what this system looks like. And you mentioned the bill that Congresswoman Jayapal and Senator Sanders have introduced. And I know some folks who are on this chat, I think, are posting, or maybe Seth can too, and our team post a link to that. I want to say thanks to Seth and to our hardworking campaign staff who are all working from home now. Thank you all for organizing this town hall. Thank you all, by the way, for joining us. And I'm trying to do justice to the questions that are coming in. So in the plan as you see it, this American Health Freedom Act, what would the role be for private insurance?
A very limited role, if any role at all. I think there probably will need to be some role, but I think the important element of this is that private insurance companies should not duplicate. They should not be selling on in the marketplace anything that is competing with the Medicare program. And I think that's very important. As long as you have private insurance companies, you're going to have incredible inefficiencies in the system. I think that there likely will be some things that insurance companies will decide that they can offer in terms of policies that are not covered. having worked for these companies for 20 years, I know the one thing they know how to do is to make money and to come out with new products and services to sell to people to get them to buy. In China, for example, Cigna has long sold dread insurance, dread disease insurance. They sell policies for people who think they might get cancer, just as an example. But I can see policies that would cover LASIK surgery or elective procedures, even plastic surgeries, or something that is beyond what is medically necessary. The other point of that is, and I don't want to get too deep in the weeds, these companies will not dry up and blow away. There will still be companies probably called United Healthcare and Cigna still around, because over the course of several years, they've been diversifying very rapidly. They have many other profit centers that are not involved in the sale of health insurance. So the notion that these companies will go away and everybody will be laid off is just not true.
We talked a lot in the transition from fossil fuels to clean energy about the need to provide assistance so that workers can take jobs in renewables instead of continuing to subsidize pollution. And it strikes me that a lot of the folks that you're talking about whose business right now is to deny claims might be better put into providing care than denying it, because we have a shortage of healthcare providers. So I just want to drill down on one point that you made, though, in terms of the role that private insurers might play. I can understand that we would want to preserve the ability for folks to provide supplemental policies for services that aren't covered by the universal plan, the cosmetic surgery or other elective procedures. Tell us the danger of having a system that would allow folks to buy policies for the same sets of services or products that are part of the universal plan. So having a duplicative role for private insurance, why doesn't that work?
Well, because the problem is there is this notion that if you have insurance companies that are so theoretically competing with each other, that costs will come down. But we have decades and decades of evidence that doesn't work. In fact, the free market does not work in health insurance and healthcare delivery either, for that matter, as it does in other sectors of the economy. It actually drives cost up because you have these inherent inefficiencies within private insurance companies. They have to have significant budgets for marketing and sales, for underwriters, for actuaries, for attorneys, and a significant percentage of what we pay in our premiums to private insurance companies goes to all of these overhead expenses to pay people like I used to be, for example, and to cover my salaries and the salaries of a few folks who make far, far more than I ever did, and to reward shareholders. So it's an incredibly inefficient and wasteful system. So we need to remove the waste from the system if we ever hope to bring down the cost of healthcare.
So when you and I are talking about the limited role for the private insurance industry, we're not talking about the very large role that those companies play now in selling Medicare Advantage plans, because we're talking about a Medicare program that is much more robust and covers the things that you're forced to go to the private market for now in Medicare. You wouldn't have to under this system.
You're exactly right. You're exactly right. One thing that would be possibly a continuing role for insurance companies, even with the traditional Medicare program, they contract with private insurance companies to do the paperwork, just the basic claims payment and things like that. But in that regard, the insurance companies don't get between you and your doctor as they do in commercial health insurance.
I know a lot of folks, again, who hear the term Medicare for All have found fault with Medicare today. Reimbursement rates are too low, benefits that are not rich enough, and then are forced to go to these private supplemental plans. But that's not the kind of program we're talking about. A lot of folks have said to me, look, I like the benefits I get now. I'm in a labor union. I've negotiated those benefits. Or I work for an employer that provides a very rich package of benefits, or I'm retired from an employer and able to continue those benefits. They want to know whether the program that you and I are proposing will actually provide coverage that is as good or better than the one that they might be leaving behind.
Yeah, not only as good or better, but also secure. We heard, now just not even more than weeks ago, as the Democratic candidates for president were debating each other, many of them were talking about how labor unions, and they were mentioning the culinary union in Nevada in particular, was not supportive of Medicare for all because they were saying they had negotiated these really good plans for their members. But when those members voted, they voted overwhelmingly for Bernie Sanders, who was supporting Medicare for all, because they know this: even if those benefits seem to be, and maybe are, better than some other folks that they know or benefit plans at other employers, there's no guarantee that it's going to be there for them tomorrow. And many of them have sadly found that to be the case. Las Vegas and Nevada have been really hard hit through this pandemic, with so many jobs lost in the casino business, the hotel business, the entertainment world. A lot of the folks who were in these union plans, plans that were negotiated by their unions that were better than some, they have no coverage now, or they're at least facing the prospect of having or of joining the ranks of the uninsured. About 26 million people, I think, have lost their jobs so far. At least those are the ones who filed for unemployment compensation, and at least 10 million of those have lost their insurance as well too. Many of those are union members as well. So people have to understand that we are all, in most cases, a layoff away from being not only unemployed but uninsured, and our families live with us.
It really speaks to the instability of the current system and the mythology that our opponents have created. You can't keep your doctor now, or
Right.
even your plan, even if you like her, because your employer may change plans, you may get laid off. I've talked to a lot of folks who say, look, I want to start a new business. I'm an entrepreneur. I've got a great idea. I want to pursue it, but I can't because I can't afford to lose my coverage. I've talked to folks who say I'm stuck in a marriage that I want out of, but I'm not willing to get a divorce.
Absolutely.
Because I don't want to lose the benefits that come with my partner or spouse. I mean, this is a system. It should be obvious by now that nobody would ever design from scratch, right? If you were sitting down with a piece of paper, you would never say, hey, we're going to make your coverage depend on your job. We're going to leave a quarter of the population or more uninsured or underinsured. We're going to let 500,000 families go bankrupt. We're going to kill tens of thousands of folks along the way. And we're going to spend twice as much as other countries to pay for all that.
Yeah.
So
it's a deal.
that's what, yes, it's a deal nobody would ever run on. And maybe I'll ask you the same question I've been asking audiences rhetorically for the last couple of years now. Tell me a politician outside of the United States who's campaigning on a promise to bring his or her constituents American-style health insurance.
Yeah.
Not a winning argument.
No, I haven't encountered one yet. And I've traveled a lot and spoken to a lot of audiences in Canada and elsewhere in the world, in many cases trying to explain the U.S. healthcare system to them. And they're using terms that have never been necessary for them to even say, much less try to understand. They're baffled. And that includes conservative politicians in both the UK and Canada, for example. They cannot understand why conservative politicians in this country are adamant against moving to a system that makes sense.
A number of folks are asking whether this will be recorded and posted and captioned, and the answer to all those questions is yes. So if you go to andrewromanoff.com, you might be on there now, unless you're logging on through Facebook or Twitter. If you go to andrewromanoff.com/live, we'll post this video and caption it. And I really appreciate your time, Wendell, and to all the thousands of folks who are joining this conversation. The number one question they're asking, the number one question I hear is how we're going to pay for it. And it's worth pointing out that we're paying twice as much already for coverage that doesn't include everybody or cover everything. So what's the best answer to this question? How do you pay for the plan that you and I are proposing?
Well, first of all, I'll start out by saying money is money. And that's where you need to start, because as you noted, we are paying an enormous amount of money to private insurance companies. The average cost of a family plan now through the workplace is over $20,000. So that's an enormous amount of money. And keep in mind that a lot of that money that we spend and send to insurance companies, like I said, about 30% of that is raked off and goes to overhead and profits and to reward already rich shareholders. So there is already a lot of money that's sloshing around in our healthcare system that is going into the pockets of shareholders and and executives and to pay for things that are just not necessary. So you can reduce a lot of that overhead. And you just also, we can have a kind of a paradigm shift in our thinking. You can either pay a private insurance company or your money goes into a single fund. And less money out of your pocket will go into that fund. Now, this brings up the four-letter word called tax, right? So people
I'm doing the math with you there. I count three. I take your point.
Yeah, you see what I'm talking about. People get hung up and they get spooked by the use of the word tax. So we often say, if you're moving to a Medicare for all type system or single payer system, it's publicly financed. So your money, again, your money is your money. Call that premium a tax, or that tax a premium. But that's one thing. The other is, so where does this tax money come from? If you are not paying insurance companies, it can come in many different forms. And there's not been a consensus on the right combination of tax dollars, but it could come in some form or fashion or combination of a payroll tax or some other kinds of tax, and taxing more income of the wealthy, and making sure that those who are the wealthiest in our society are paying a bit more through taxation.
So tell me if I've got the numbers right here, because I want to make sure we do the math. If we're spending more than $10,000 per person per year on existing taxes and premiums and copays and deductibles and out-of-pocket expenses, largely to for-profit insurance industry, and we could cut that bill in half. I know that this requires more than just a switch to Medicare for all, but if we could do the sorts of things that would reduce the budget in half, but instead of paying those premiums and deductibles to a private for-profit insurance industry, if we paid half as much to the government in the form of a tax, strikes me as a pretty substantial savings for American families.
It would be a substantial savings for almost every family, except those at the very top of the income spectrum. Some of those guys might have to pay a bit more than they're paying now, but they can afford it. The rest of us cannot afford a system that has premiums and out-of-pockets going up every single year. The other thing that's being, as proposed already by the bills before the House and the Senate, employers, they would continue to contribute to our health care, but they would pay less than they're paying now. Employers are fed up with this system. In fact, one of the organizations that I lead is called Business for Medicare for All. Increasingly, employers are saying, this doesn't work for us anymore. And more employers are getting out of providing coverage. They have to, they can't afford it. Over the past 20 years, the percentage of Americans and the number of Americans getting coverage through the workplace has continued to drop. And of course, right now, as we speak, probably today, tens of thousands of people will be dropped out of the system because of that employer-based system.
I was going to ask you a little later why and you're part of the solution here, but why the push for this kind of universal single payer plan isn't coming more from employers. I ran effectively a small business for 4 years. We had about 18 employees. We picked up the tab by and large for their premiums, although we couldn't afford to cover everything. And it struck me that putting myself as an employer in between my employees and their health insurance or their health care was a very strange role. Why was I asking them about their health needs when it's none of my business? And arguably an incentive to discriminate, as happens in reality. I want to just stick there with the cost, because I asked my team, and we had a circle of experts who helped us formulate a plan and put me in the same position as you are. I came out actually for universal single payer healthcare a decade ago when the Affordable Care Act negotiations were beginning. So we said, okay, if the US is spending excess of $10,000 per person and other industrialized countries are spending $5,000 or $6,000 per person, where's the extra money going to? Because it's not going to the sorts of things that make us healthier. Can you help us just, I know we talked about this earlier, but just tick off the things that our excess spending is paying for?
Having worked for two big insurance companies, I can tell you that there's just all kinds of ways that those companies have to take money that we think might go to making sure that we get the care that we need that really doesn't. They really employ armies of underwriters, actuaries, as I mentioned, But also some of the highest paid people within insurance companies are in sales and marketing, sales in particular. So that's one thing. High advertising cost, which is not known in any other system in the world. Things that are put in place to make it more difficult for us to get the care that we need. There are different ways to try to control the healthcare cost in private insurance. One is to try to reduce the unit cost of goods and services. They can't do that, so they try to make it more difficult for us to get the care that we need through prior authorization. That young woman, and that 17-year-old girl in California I mentioned, Natalie Sarkeesian, that's an example, and it's only gotten worse in those years in which doctors and nurses who are treating you have to ask for permission before they can go forward with a treatment. The people who are running the high deductible portions of our healthcare system or our health insurance programs, all of that is unnecessary and will go away when we finally get to the American Healthcare Freedom Act.
I'm glad you're helping me popularize this title. I didn't even put it up on the website yet. I just coined it a few months back at a town hall like this. And by the way, if you want to learn more about my platform, you can go to andrewromanoff.com. I'm running for the United States Senate. My staff reminds me to explain that in case we run out the clock here. I'm running to unseat Cory Gardner, who is a Trump ally in the Senate, considered the most vulnerable Republican in the entire chamber. If you want to help out, you can go to andrewromanoff.com, check out our platform, get involved, contribute, volunteer. We're up against an army here, and I want to turn to the politics in a moment, but it's pretty clear that this position that you and I are taking here, Wendell, is not popular with the establishment on both sides of the aisle in DC. I'm up against a very well-funded Democratic opponent here in Colorado. I have to get through the primary June 30th before I have a chance to knock off Cory Gardner. But one of the concerns I've heard from a lot of the folks I've met is that we're somehow proposing to take everybody off of the health insurance plans they have tomorrow and put them on this universal single payer plan. I haven't actually heard anybody propose an overnight transition. So let me ask you, how do we we'll put the politics aside, but just the mechanics, how do we get from where we are to where we want to be?
You know, there's a number of ways you can do it. Even Joe Biden now is saying, let's begin to lower the age of eligibility for Medicare, and he's proposing maybe lowering it from 65 to 60. I think probably if you take that route, you should at least go down to 55, and you can begin to enroll people at birth into Medicare or Medicare for All, or the Freedom Act, whatever you decide to call it. So there are different ways of doing it. And even there's going to be legislation introduced next week that will, of those who are newly unemployed and uninsured, to open up the Medicare program to enroll them. So there are various ways of doing that. We've done this over the course of the history of the Medicare program. Several years ago, it was broadened to include people who have kidney disease and people with other disabilities who are now eligible for Medicare. So there are ways of doing this gradually. You can bring people in based on their age into the system, but it would be a transition over a number of years to do that. I want to go back to just one other thing before I forget it, about where the money goes that we pay. It goes, a lot of it, to executive compensation and to shareholders. Just this past week, United Healthcare, which is the biggest, announced that just in the first 3 months of this year, it made profits of over $5 billion. And that company rewarded its top just seven people who work for the company, $179 million. So a lot of the money that we pay rewards those guys and the shareholders, and their institutional investors are making money hand over fist. Since the Affordable Care Act was passed, those companies have gotten richer and richer, and so have their shareholders. So that's where a lot of our money goes.
It's pretty clear that the problem in America, at least in my view, is not that we're spending too little on healthcare, it's that we're spending too much and in a lot of the wrong places. I think it's also worth pointing out, tell me if my history is right here too, that we've already made a commitment as a country to provide universal care, at least at one point, in the emergency room, because it was Ronald Reagan who signed a law called EMTALA in 1986 that says if you want Medicare dollars and you're a hospital, you've got to take everybody who comes in need of emergency care, even if they don't have coverage or the ability to pay. I happen to think that was the right decision for a moral society to make. You don't let people drop dead on the doorstep of an ER. But if you agree with that, it strikes me, we ought to be willing to help folks get the care they need before they end up in the emergency room and invest in prevention and early intervention. Certainly be healthier for them and cheaper for all of us.
That's exactly right. And that's one of the areas where we also fall far short of other developed countries. If you have a system that is more rational, in which our resources that we allocate now are reallocated, you will have money that you can use to invest in keeping people from getting sick in the first place. We spend so little, just as an example, on public health in this country. Only about 3% of that $3.6 trillion that we spend every year goes to public health, goes to having a public health infrastructure that would have put us in a better position to do a lot better than we're doing now in this pandemic. But we have we've devoted the money that we spend to reward shareholders rather than building up the public health infrastructure and to focus on preventive care. We just have not done that.
You talked a little bit, Wendell, about a transition plan. And as I read the early history of Medicare itself, the proponents were not prepared to just declare victory when we got everybody covered at 65. Thank God, if you get to be 65, you've got coverage, at least for the time being, under existing law that can never be taken away. But what if you're 64? I met a woman in Greeley here in Colorado not long ago who needed spinal surgery, couldn't afford it, 64 years old. She said, I decided to roll the dice, wait until I'm old enough to qualify for Medicare. She did. She got the surgery. She walked into the brew pub where he hosted an event where I met her. And thank goodness she survived. But what if she had been 63 or 62? What if she had been 26? That's a magic age too, right? Because you just aged out of your parents' plan. So this system isn't really a system at all. It strikes me as just a patchwork of laws we've assembled and programs we've created to which there's no great rhyme or reason.
Oh, it's exactly right. It is a patchwork, and our health insurance is regulated by all the 50 states, not very much at the federal level. So it is a patchwork in so many different ways. And I've been to Colorado many times. I've spoken to a lot of people, and people in Colorado have told me that they have been counting the days, years, months, and days until they're eligible for Medicare. People who are enrolled in private insurance, because they're not being able to get the care that they need, or they're having a hard time paying the premiums that they have to pay, or to cover their out-of-pocket expenses. I hear it all the time.
It's I'm no relation, but it feels like a game of Russian roulette. Speaking as a Romanov here, and it's heartbreaking and dangerous and expensive and tragic. You talked a little bit about lowering the age of eligibility or starting at birth and going the other way. How long do you suppose it would take for us to get to universal coverage if we lowered or the age of eligibility or started at birth?
Well, even under the Sanders plan, there's a transition of 4 years, and I think you need to do it pretty readily. I think there are a lot of people who are hurting out there, people who are eager to send our system to the dust heap or ash heap of history. So I think it can be done, but it needs to be done in somewhat of a transitional way. And I would argue that 4 years makes a lot of sense. The longer you delay that or stretch it out, the more opportunities there are for opponents of this effort to try to undo it or roll it back. We've seen that happen many times. Under the legislation in the House, it's just a 2-year transition. That might be too aggressive, but you need to do it sooner rather than later. And even those people who you hear are happy with their health insurance, I haven't met that person yet. I hear that they exist. But like you said, people are, they might say that people appreciate what they have, because in many cases they don't know what could be better. So there is that. But on the other hand, there are a lot of people who have tested the limits of their health insurance companies and really understand that their coverage is inadequate. And they've had to turn to GoFundMe to beg for money, or to the bankruptcy court, even with insurance. So there is a growing number of Americans who understand the system doesn't work for them. And I think they would be supportive of a system that moves us pretty quickly to universal health care.
A couple quick thoughts. I haven't like you, I haven't met a lot of folks who say, whatever you do, please don't touch my Anthem, my United, my Cigna. I have met folks who say, I want to keep my doctor. And obviously the benefit of a universal, maybe not so obviously, but the benefit of a universal single payer plan, unlike the system we have now, is that all those providers would be in the network. So you wouldn't face the situation that so many do, especially in the mental health field where I've worked, where people are forced to go out of network more often, or pay more, or wait longer, or travel farther, or go without care altogether. And again, I have met folks who say, whatever you do, make sure the benefits are at least as good or better. And to your point, Wendell, earlier, that those benefits are secure and can't be taken away.
Yep.
When it comes to this transition, a lot of folks have said, well, why don't you start with a public option? The proposal that was on the table and swiftly taken off in the Affordable Care Act negotiations a decade ago. Why don't you start with a plan like Medicare for all who want it, and then that plan, if popular, would be able to compete and eventually get to a universal pool. What's wrong with that?
Well, I think there is some merit in considering a public option, and 10 years ago, it was as good as we could possibly have gotten, but the insurance industry wanted to make sure that was stripped out of the legislation, and as you noted, it was. But here's the problem with that. The devil is in the details, and we need to make sure if policymakers think that is a step toward Medicare for all, then I'm open to considering it if it is seen as a step on the way, and that we have a time frame to get us to universal coverage. But the problem is, we can expect my old industry, the insurance industry, to try to game the system and to make sure that a public option is structured in ways that will not be what we need. We would need to have one that doesn't resemble private insurance companies. We need to have a system in which people don't have these high out-of-pocket costs, and in which the government is able to negotiate directly with drug companies. But here's the other thing too. One of the problems with having that is that it would be expected that a public option would be especially appealing to those who have pre-existing conditions, who have high healthcare needs. So they would gravitate toward that. You would have what the insurance industry would do would be to cherry pick and be able to cherry pick the youngest and the healthiest and offer cut rate policies to get them to enroll in those private plans. That would make it more expensive for the public option to operate. We saw this happen years and years ago, and the reason why we have the system we have now. Keep this in mind, that when our system of health insurance in this country began, all of the health insurance companies were nonprofit. But then big for-profit insurance companies saw a way to make a difference. In the beginning, it was what is referred to as there were community-rated health plans. They didn't discriminate based on age or gender or health status or income or anything like that. But then the insurance companies came in and said, we will, if you are young and healthy, we'll sell you policies at a reduced rate. And that screwed everything up. And it led us to where we are now. You can be certain that the insurance industry would do exactly the same thing all over again.
Is the problem that the companies are private or that they're for profit? Because some folks are suggesting, both in the course of this conversation and others we've had, that we could get closer to where we need to be if we had non-profit insurance plans, either one or several competing. And I know there are other countries with that model in place. Better than the system we have now?
It would be better than the system we have now. But good luck getting these big companies to change their tax status, because they make so much money. But you're exactly right. One of the big problems we have now is because we allowed health insurance companies several years ago to convert to for-profit status. A lot of the Blue Cross plans around the country now are for-profit. Some are still operating on a non-profit basis. But also know this, they don't share a genuine desire to get everyone covered. Even if you are a non-profit health insurance company, it's not your ultimate goal to get everyone covered. It is to operate as a business. So unless there is some federal means of making sure that we have everyone covered, more than we've done now, just having a system of private health insurance companies is not going to get us to where we need to be.
Kaiser's a big insurer here. What does Kaiser look like in this world of universal single-payer healthcare? Do they go away? Did the Permanente Medical Group stay and the insurance plan go away?
I think their medical group would absolutely stay, because they, over many years, have been lauded, I think appropriately so, for having a pretty good system of integrated care. Been very popular in California and the West Coast and Colorado and a few other places. And people do like that as an alternative to some of the other insurance companies, in particular the for-profit ones. But they've built a system of hospitals. They own and operate a lot of facilities in the markets where they serve, as well as employ physicians. So The delivery system absolutely could stay in place. But there's, I think that the component that would be replaced would be the health insurance side.
And I know a lot of folks who are chiming into the conversation, as I can see in the chat bar, are praising the Kaiser docs they get, and consistent with the point that you're making and the distinction that we're trying to draw between the provision of care and the value of a single public insurance pool. I know we haven't done justice to the conversation about the delivery of healthcare. We'll save that. We'll try to lure you back for another conversation and expand the panel as well. Panel of one. I'm lucky to have you here. But I want to, in the few minutes we have left, talk about the politics. We talked a little bit about the problem. We talked about the solution that I think you and I both support. These politics keep getting in the way, and in part because the same industry that stands to lose is bankrolling the people who are making these decisions. I should point out, as a shameless plug here, that my campaign accepts no PAC contributions. Our campaign is funded entirely by people, about 80% of them people in Colorado, 100% of them humans, because we don't take any corporate cash. And if you want to help us keep this campaign going and help win the Democratic nomination and defeat Cory Gardner and flip the Senate, go to andrewromanoff.com and chip in, andrewromanoff.com. This is a people-powered, grassroots, retail, PAC-free campaign, so I hope that you'll help. Speaking of the politics, one of my opponents in this race described the sort of proposals that you and I are talking about here, Wendell, as, and I'm quoting here, the discredited ideas of Karl Marx and Joseph Stalin. That wasn't Cory Gardner, although he uses the same language. It was John Hickenlooper who compared this to Stalinism. I'll defer to you. I don't know what to say about that.
No, that's just absolutely outrageous. And to be honest with you, despicable that someone who calls himself a Democrat would say anything quite like that, anything approaching that. It's just absolutely absurd and not at all the truth. It is absolutely saying what the insurance industry wants him to say. And I've written a lot about things like this. I wrote a book called Nation on the Take, How Big Money is Corrupting Our Democracy and What We Can Do About It. And a lot of Democrats are as much on the take from the big special interest as Republicans are. And I've documented that. And I know when in my old job, I used to hand out money from the Cigna PAC, and we would often give more money to Democrats than to Republicans. It depends on how the political winds are shifting. But that's absolutely untrue and outrageous. When you write a big check to a candidate, you can expect in return that that candidate is going to say things that bolsters your point of view or your argument or will be there when you need them. That's why they're able and do write these big campaign checks to people like that.
I recall the phrase, you dance with them that brung you. A former colleague of mine and a wonderful friend and mentor, the late Ken Gordon, used to tell candidates who would promise that they would vote independently of their corporate donors, they would say to Ken, I can take their money and vote against them every time. And Ken would shut them down with one question. He would say, well, have you told them that? It's pretty clear that these interest groups are bankrolling politicians on both sides of the aisle because, as you said, they get something in return. I know this is a family show, but most people would call that corrupt. It's a form of bribery that we've legalized in America, and it strikes me that the best way to get the kind of changes that you and I are proposing through the system, whether it's healthcare reform or climate action or other changes, is to change the way that we finance campaigns. Exactly. We haven't done that yet, so we still have a system that sells Senate seats to the highest bidder. So how do we build the kind of coalition? You're already leading this charge. How do we take what I view to be a consensus among the majority of Americans, even an uptick we've seen during the pandemic, support for a plan, a universal single payer plan? How do we translate that public sentiment into action in Washington?
Well, doing what you and I are doing now, I, by the way, have talked to and will be doing something similar to a lot of other candidates. There are many, many candidates who are running for the Senate and for Congress who support moving to universal health care, to Medicare for all, whatever, the Freedom Act. But that's one thing, is to support and donate to candidates who are running and who are saying they will not accept corporate donations. I think that's very important. We do need to address campaign finance reform. That's got to be something that we do, and I know that you support that. We've got to do both. There's Charlie. We've got to Charlie's my office mate here. We've got to attack the corruption in our political system. while we are working on improving our healthcare system. We've got to do both at the same time. We can chew gum and walk at the same time.
That's a bold promise. I take your point, and I'm eager to have this debate. You know, our friend, and he's a friend, John Hickenlooper, skipped 19 of our debates in the course of this campaign, even before the pandemic made physical debates impossible. So we reached out to him, suggested we have a series of debates between now and June. The ballots in this race go out on June 8th, so it's not just June 30th that we're worried about. It's more than a fortnight of voting that takes place all by mail in Colorado. I hope you might be willing to rejoin us too, because I know that we got many more questions in the course of the 60 minutes we shared here than we were able to address. It strikes me that this is going to be a heavy lift, even if we hold the House, replace the president, flip the Senate. It'll be hard to pass this kind of major change, but it'll be impossible if we have to fight other Democrats along the way. Democrats, as you said, who are parroting the talking points of the insurance industry.
You're exactly right. We have to. It is going to be a heavy lift, but I wouldn't be doing this. I wouldn't still be in the game if I didn't think that it was possible, and if we didn't, if you didn't have candidates like you who are understanding the importance of fighting for this, it can be done. And there are a lot of advocacy groups and individuals, like we said earlier. More and more people are coming around to understand just how messed up our system is and how corrupt it is. So I think those who support this are going to be out also in large numbers and helping you and candidates like in other places to help us move forward. Bernie Sanders talked a lot about a movement. It actually does exist. And we're going to see more and more evidence of that as we go through and come out of the other end of this pandemic too, by the way.
I know folks can follow you at Wendell Potter. Where else can they turn to learn more of your work and to read some of your books?
Take a look at the two organizations that I lead. One is called MedicareForAllNow.org. It's a small dollar donation. It's a nonprofit organization. And BusinessForMedicareForAll.org. It's the organization that makes the business case for moving to Medicare for all. And we speak for businesses that are just fed up with this system as well, too. So look for us there. And yes, at Wendell Potter. And on Facebook as well.
I'm at Andrew. My website's AndrewRomanoff.com. Our Twitter and Facebook and Instagram handles are at Romanoff2020. We're doing these town halls every Friday at noon, every Tuesday at 5, both in Mountain Time. I'm reminded of a quotation that's, I think, apocryphally attributed to Winston Churchill. He supposedly said, "You can always count on the American people to do the right thing after they've exhausted all the other options." I don't think Churchill actually said that, but he should have. And it strikes me as maybe the silver lining here is that we have created a system that doesn't work for so many folks, and we will get from here to there. It shouldn't have taken a pandemic to do so, but maybe in the aftermath, in the recovery, in the rebuilding that takes place, we can avoid just going back to normal, because normal wasn't working.
Exactly. I think Winston Churchill is right. We've tried all those alternatives, and now it's time to really get down and do the right thing.
Good words to end on. I'll attribute that now to both you and Winston Churchill. I want to say thank you very much, Wendell. It really means a lot to me that you're willing to share so much of your time with us. It's not our first conversation. I hope it won't be our last. I want to say thanks to the several thousand folks. We'll have an exact count later. Our system didn't crash today. That was encouraging. I want to say thanks to Seth and to our team who organized this town hall and every town hall. I hope you'll continue to tune in. You can find me again at AndrewRomanoff.com. To Wendell Potter, to Charlie Potter, who is at your side there, I want to say thanks again. There are millions of folks who are going to be able to live longer and healthier and happier lives because of the leadership that you're providing. And that means a lot to me as an American. Thank you.
Thank you, Andrew. And have me back anytime. Happy to help.
Thanks very much.
Thank you.
Thank you all.